So the urine color tells you things, important things, like whether or not the patient has a concentrated or diluted urine. Remember, the kidney does a very good job concentrating or diluting depending on what's appropriate. If you drink a bunch of water, your kidneys are going to work very hard to dump the water. Otherwise, you're going to become hyponatremic. And by the same token, if you're dehydrated or bleeding, the kidney does an excellent job concentrating the urine. So the color can give you valuable information when you're seeing the patient in the hospital. Also, if you see a dark color urine, you can think about ATN. We were talking about acute tuberous necrosis. But you can also see different urine colors, like red when you have a patient with hematuria. But on your boards, you may encounter a patient with rhabdomyolysis. Have you guys heard about rhabdo? Mm-hmm. So maybe some patient with, exactly. Maybe somebody taking, let's say, a wrong combination, like let's say high-dose simvastatin with diltiazem. Mm-hmm. Those patients can go into rhabdo. And one of the things that they want to treat here, they want to show you, they're going to show you a UA testing positive for blood, but no RBCs in the urine. So the reason for being positive is because that test, it tested positive for myoglobin, which is the protein that's toxic to the kidney. It causes, it clogs up the tubules and it causes ATM from a ischemic type of injury. But also, you can also see red urine sediments in other conditions. You're not going to see this probably ever. I've never seen it. Porphyrias, or sometimes there are a group of medicines that we prescribe for analgesia of the urinary tract. Have you guys heard about?
Phenazol.
Yeah, phenazopyridines. I think that has a name. Azole. I think Azole. They sell it over the counter. So patients frequently buy that because it's an analgesic of the urinary tract. You take it and that's excreted in the kidney, and that makes your urine orange or red. And the patients freak out. If you don't tell them, they freak out. They call you, I'm peeing urine. So if you end up prescribing that or telling the patients to buy that, make sure you tell them that the urine is going to cause urine discoloration.
That's for UTI, right?
Yeah, azole or phenazopyridines. And then also some medications like rifampin can give you orange color urine, and that's another thing that usually we advise patients. We only prescribe. We don't prescribe rifampin anymore. Before, we used to use it for everything upper respiratory infection because it's very effective. But that's a medication that more or less is only used by infectious disease doctors because it's one of the very effective weapons that we have against tuberculosis. And we don't want to abuse this medication. But anyway, so you can see this is a red-orange urine that is from rifampin use. You can also see hyaline in the urine. I don't know if you've ever heard of that. Like, it looks completely white, and you can see that in some parasitic diseases. You're never going to see these probably not even in your boards. Or you can also get it with trauma, pregnancy, and some congenital defects. It's just chyle somehow making its way to the bladder, either via fistula or some sort of like traumatic fistula creation. You can see green urine. Again, this is Pseudomonas. Remember Pseudomonas? Have you ever? I'm sure you learn about Pseudomonas. It's a very aggressive organism. It can affect anything, any part of your body. But we see pneumonia, and you can also develop a pyelonephritis with Pseudomonas, and this is the urine color, believe it or not. But you can also see like some exogenous chemicals and drugs, like propofol can give you a green urine, and some dyes in the enterophytes. You can sometimes see purple urine, but this is a rare infection. It's a type of bacteria called Providencia stuarti, and this is more like a rare case. I've never seen it, but just wanted to cover it. Okay, so the turbidity, that's another thing that they analyze when they report a UA, and it's the normal urine we all know is transparent, but it can become turbid because there's an increase in some particles. More commonly, we see it in infection, when the patients are heavily bleeding, or when there is a contamination from genital secretions. You know how sometimes they report urine mucus? So that's probably an improperly collected urine sample. So the proper technique for collecting a urine sample, you need to ask your patient to wipe, male or female, they should wipe. They should discard the first portion, the very first portion of the urine, and they should do a clean catch from the midstream urine. And but also, it's important to recognize that not every urine that's clear is a healthy urine. You can still have pathologic urine and look completely normal, like patients with kidney disease. So the odor, back in the days, they used to ask doctors to smell the urine. Thank God we don't encourage that practice anymore. But you can see, when you have uremic patients have a lot of ammonia, or the patients when they have a bacterial UTI, it can be pretty potent. But you can also have like a sweet or fruity odor when you have DKA. I don't know if you've ever seen a patient with DKA, but you're gonna encounter this type of problem. Maple syrup urine, there's a very specific genetic condition, and again, I don't think you're gonna be testing these things. But there's a condition called hypermethionemia, and they call it the fishy odor urine. So it's gonna be awful. I don't think we're ever gonna smell that. Okay, so the density. You guys know why we do the specific gravity in the urine? Why is it important to do specific gravity? So the specific gravity gives us information about dilution. Like if the urine is diluted, the specific gravity tends to be very diluted, like 1,000 to 1,003. We can see this in diabetes insipidus. That's why we use it to diagnose diabetes insipidus. Or we can see this in water intoxication. Do you know which patients get water intoxicated, by the way?
College students. Hazing. Doing hazing.
Doing the hazing or doing the methamphetamines. So so ecstasies actually holds on, it enhances, potentiate the effect of antidiuretic hormone in the kidney. And these patients, they get the wrong advice from their peers telling them, you've got to drink because you're going to party, you're going to get dehydrated. And sure enough, these patients, they start seizing and they die. I saw a young woman dying from using ecstasies and drinking a lot of water from hyponatremia. So when we see this very dilute urine, you know that you're dealing with a patient. The other scenario they may give you on your boards is somebody with polydipsia, psychogenic polydipsia, like a crazy patient, drinking a lot. And how do you catch them? It's a simple test. You tell them to do a UA at 6 a.m. and you tell them to do a UA at 1 p.m. The UA at 6 a.m. is probably going to be concentrated, right? Because that's what the kidney does. The kidney concentrates and he's not drinking because he was sleeping. But the repeat UA at 1 p.m. is going to be quite diluted, or the specific gravity is going to be very low. So, I always look at like I was telling you yesterday, like I use every piece of information, as a grain of salt and make my interpretation of the studies based on everything. But you can see an increase in specific gravity in patients with like some sort of extrinsic osmotic agent, like for instance if they have contrast, or if the patient is pretty hyperglycemic. Remember the glucose is not an effective osmol, but when it's too much, it does work as an effective osmol. And the urine pH, we also analyze the urine pH because there's some diseases that are more commonly seen in acidic urine. Do you guys know which conditions are more commonly seen in acidic urine? So uric acid, kidney stones. So it almost never forms in an alkaline urine. It tends to form in acidic urine. And one of the therapeutic goals for these patients is that we try to increase the urine pH. We try to make it at least 6.5 or greater, and we give them a medication called potassium citrate. I don't know if you've seen it before, but potassium citrate is very effective raising the urine pH. Another strategy is to tell the patients to become vegetarian, because if you analyze the urine of a vegetarian patient, more likely they have pure vegans, they have like alkaline urines. Okay, and then it also has an important therapeutic role in some intoxications like salicylates. Like we alkalinize the patient's urine to be able to facilitate renal excretion of salicylate. But I always look at the UA. You're gonna get this information. Sometimes you don't even know why they put it there, but there's some therapeutic use or some interpretation that I wanted to cover. So the osmolarity, depends on the number of particles present. And most of the osmolality is determined by the urine sodium and the urine potassium and the urine chloride. And why is it important? In medicine, we use urine osmolality to approach hyponatremia care. Like most patients with hyponatremia, they have a water excess problem, and they don't have a salt deficiency problem. So they tend to have they tend to have very low urine osmolality, and you can actually classify. I'm so sorry. Hello. For workup and diagnosis of hyponatremia. If we have time today, we can talk a little bit of hyponatremia because you're going to get some questions about hyponatremia. So, but the more significant determinants of urine osmolality are the urine sodium and the urine potassium for the most part. And I'll show you some slides about hyponatremia. Okay. Hemoglobin, I already told you, if you have a positive on your board, so you have a patient with positive blood but no RBCs, that's a rhabdo case until proven otherwise. And they love to ask those questions. And which patients get rhabdo again? You said statins. Who else? Heat stroke, right? Patients that are working on very hot and humid conditions, and they end up developing a heat stroke. Also, some patients with ischemia, like when the patients present with like an ischemic limb, or trauma patients when they need a fasciotomy. Those patients, they go into rhabdo, and one of the complications of rhabdo is acute renal failure from ATN. But it's the myoglobin actually being toxic to the kidney. But you can also have like a false positive result when you have a patient with taking a lot of vitamin C, can give you a false positive myoglobin in the urine. And so the dipstick has a very high specificity, but it has a low sensitivity. Okay, glucose. We test for glucose, and basically you can see false negative results in the presence of, like, again, vitamin C and bacteria because of the metabolism, bacterial metabolism. And but you can also, but it's very sensitive actually. Do you guys remember what the nadir for glucose excretion in the kidney is? You guys remember? The glucose, the curve. You know, if you have a diabetic patient and you start seeing glucose in the urine, that means that the patient's sugar is pretty high. It's already like probably like greater than, you know, like around 180 to 200. You start seeing the presence of glucose in the urine, but you're not supposed to see glucose in a non-diabetic urine. So when you see a patient with glucose in the urine, you think about diabetes, or you can think about other weird syndromes like Fanconi syndrome, which is, we see that with multiple myeloma. We're going to talk about that. Okay, so protein in the urine. I already told you guys how much protein you're supposed to be in 24 hours. Let's see if you remember what we talked about yesterday.
0.2.
You almost got it, but you're telling me grams or milligrams?
Almost
Yeah.
nothing. It should be like almost nothing.
It's 150 at the most. If you exercise, 150 milligrams in a 24-hour period. If you exercise, that number can be higher. That's why when we're going to do a 24-hour urine collection, we always advise patients to not to exercise a lot. But physiologic proteinuria shouldn't exceed like 150, probably 200 milligrams in a 24-hour. So the dipstick changes. This dipstick assessment is highly sensitive actually for albumin detection, but it has very low sensitivity for other proteins like tubular proteins or light chains or immunoglobulins. So on your boards, you know, you're gonna get a question with a patient with multiple myeloma. Multiple myeloma is a blood cell dyscrasia. It's characterized by monoclonal production of B cells, and these patients they end up having a lot of these sticky proteins that they go into the kidneys, and they stick to a protein that's produced by the tubules, and it forms like this very insoluble protein matrix, causing renal failure. The point that I'm trying to make for your boards is that they're going to give you a patient, old guy with anemia, bone pain or back pain and some kidney abnormalities, and they're gonna show you a UA from this patient, and they're gonna show that the patient really had no protein in the urine when they did the dipstick, and the patient had a lot of protein when they actually did a quantification of proteinuria. We call that mismatch. Mismatch because you're expected to see the same degree of protein if I do the dipstick versus doing the quantifications. The problem is that the patients don't have, when they do the dipstick, they don't have the sulfacylic acid assay. Therefore, the protein in the urine in the dipstick shows negative, but when they do the quantification, either with a spot urine for protein creatinine or with a 24-hour urine collection, it shows because they run the sulfacylic acid, and that tells you that there is a non-albumin protein in the urine. And that non-albumin protein in the urine comes from the multiple myeloma. So when you guys see that, I want you to pay attention if you get multiple myeloma questions, because that's a board favorite. I'll tell you, every time I took my boards, I got like 3 multiple myeloma questions. So that's a condition you need to understand. Okay, so there's 2 ways of quantifying protein. Actually, there's 3 ways of quantifying protein in the urine. One is what we do in primary care. It's called the microalbumin creatinine ratio. And I told you guys yesterday that the definition of microalbumin is less than what? Let's see if you guys remember. If it's greater than what number, we call it proteinuria. So,
150?
no, 150. Remember, less than 150 is normal. 150 to 400, that's microalbuminuria, right? And then greater than 400, we call that proteinuria. So I usually order the 24-hour protein excretion or like a protein creatinine ratio, a random urine sample. Why one versus the other? Because the 24-hour urine, at least I do it one time to understand how much protein excretion. But it's an inconvenient test because if you realize you have to pee for 24 hours in the same bucket, you have to refrigerate it, you have to take it to the hospital, it's pretty inconvenient. Whereas the spot urine is probably as beneficial and it's very convenient. The patient just goes to get the blood work done, they give him a cup, you urinate, they measure it, and that's it. But there's some conditions where it's better to do the 24-hour. Like for instance, if I'm actively treating a patient with glomerulonephritis, it's better to do a 24-hour urine rather than just do spot urine. Okay, so leukocyte esterase. Have you guys seen that on the UAs? So the dipstick detects the leukocyte esterase that is released from the granulocytes and the macrophages. You know, it's an enzyme. It's only present in the monocytes and the macrophages. So when you see that, you think about the patients having a UTI, but you can also have false positive and false negatives. So a false positive can rarely, can occur when they use formaldehyde as a preservative, or you can also have a false negative when you have like patients taking some sort of antibiotics. But the bottom line that I want to make for you guys is that it's a sensitive test, but it's non-specific. So if you see leukocyte esterase, it doesn't mean that your patient has a UTI, because if your patient has blood in the urine, or the patient has WBCs in the urine, you can still have a positive leukocyte esterase, and yet you don't have a urinary tract infection. That's why it's so important that we always do a culture. And I don't know if they explained that to you guys in school. You need to have a culture to call it a UTI. We treat these patients for the most part, but it's very important. It's common practice to send the culture. Okay, so they need nitrates. It's they sell them over the counter. Sometimes your patients are going to call you and say, like, I have these sticks and they're telling me I have a urinary tract infection. So the nitrates detects the bacteria that produce nitrates, but not all bacteria produce nitrates. The more common ones are basically the Pseudomonas, Staph, Enterococcus, and you can sometimes have a false positive result if you have a lot of vegetables. They contain a lot of nitrates. So again, I use this information with a grain of salt. If I see a patient with symptoms, classic symptoms of UTI, plus you see a leukocyte esterase, you see nitrates, you see WBC in the urine, sure enough you're dealing with a urinary tract infection. But that's the reason why they're going to report those things when you send a UA. So you can also detect urine ketones. Obviously, that's not good. That means that your patient is probably going into DKA and should never be present unless your patient has a prolonged fasting or DKA. And bile pigments you can see, but only conjugated bilirubin is passed into the urine. So if you have a patient with obstructive jaundice, I don't know if you cover any hepatology talks, but you can have a obstructive jaundice or jaundice due to hepatocellular injury. You can see basically conjugated bilirubin. So the total bilirubin, you can see it elevated, and the patient's urine can look pretty ugly. Very good. So moving on to the slides about RPGNs. So having blood in the urine, what's the most common cause of having blood in the urine, guys? Do you guys know? In females.
That's UTI.
In females.
Or menses.
Menses.
Yeah.
So that's a very commonly missed thing. Like doctors don't even think that happens all the time, and they end up doing a lot of workup. So if you see blood, you need to find out when was the last time surgery and things like that. In males, you can see it from BPH. You can see it from trauma. You can see it from cancer, bladder cancer. That's one of the that's one of the first early signs of bladder cancer. My grandma died from bladder cancer, and the doctor was mismanaging. I was in med school back then, but the doctor was mismanaging her because the UA was repeatedly abnormal, and he never did cultures. He was just treating her as a UTI, and sure enough, he had an invasive tumor by the time they were able to get to her, and she passed. So not every abnormal UA is a UTI. That's the point that I'm trying to make. But there's two types of there's two types of hematuria. Either hematuria from the urinary tract or glomerular hematuria. Glomerular hematuria is pathognomonic of kidney disease, and it's never normal. It's something that needs to be worked out, and most of these patients, they end up getting a kidney biopsy. But you can see most of the times you have hematuria coming from the urinary tract. So there is one type of cell called the dysmorphic RBCs. I don't know if you heard about dysmorphic. So the isomorphic, it's basically, you can see, you need to answer the phone?
I was going to, that's okay.
So the isomorphic, you can see like the RBCs have a normal configuration. Sometimes you can see crenation of the RBCs in the urine. That's not a dysmorphic. Dysmorphic means that basically the patient's the RBC has been shaped, has been deformed as it's passing through the glomeruli, and we call this the Mickey Mouse cell. I don't know if you heard about these cells. This is the classic dysmorphic cell. Let me see if I have. But if you pay attention to this, you see these little blebs. Sometimes they call it Mickey Mouse RBCs in the urine. We call those acanthocytes. So acanthocytes are pathognomonic of glomerular hematuria, and they need to be worked up. And that's basically I'm gonna tell you later when we talk about RPGNs. So
you said it's glomerular
hematuria. Glomerular hematuria is abnormal. It's coming from the kidneys, and you better work it out. Okay, so the urine microscopy, you can also see leukocytes. And leukocytes can either be neutrophils, eosinophils, lymphocytes, macrophages. It's almost impossible to distinguish them. So, but if you see WBCs in the urine, it may be from acute interstitial nephritis. Have you guys heard about that condition before? Acute interstitial nephritis. So it's like an allergic form of inflammation of the kidneys. We see that with NSAIDs, but we also see that with some antibiotics. And the most common antibiotic causing acute interstitial nephritis are cephalosporins. But we also see that with other drug types like PPIs, actually proton pump inhibitors. They can also give you a acute interstitial nephritis. But we also see WBCs in any type of infectious process of the urinary tract. You call it urethritis, cystitis, prostatitis, pyelonephritis. All of them can give you a lot of WBCs. And yesterday I mentioned briefly about renal tuberculosis, right? So, a sterile pyuria, if they give you a question on your boards, with a sterile pyuria, meaning that the patient has a bunch of WBCs, but both the urine culture is negative, you think about two entities. You think about acute interstitial nephritis, and you think about tuberculosis, renal tuberculosis. For acute interstitial nephritis, you need to biopsy the patient to establish the diagnosis. But most of the time we don't have to biopsy because we stop the offending medication and the kidney normalizes. But when it doesn't normalize, despite discontinuation, that's when you need to do a biopsy. And for renal tuberculosis, you need to do a urine AFP culture. It's rare, but
AFP?
AFP, acid fast bacilli. That's the standard culture for any type of tuberculosis. In LA, everything's possible. We have a large population coming from all over the world. And at County, Olive View, they have the only tuberculosis unit in the whole state of California. Like some of those patients, they were hospitalized for years, and including patients with multi-drug resistant tuberculosis. So everything's possible in LA. Okay, so cells, I think this is so important for you guys. Squamous cells. You can see squamous cells. They're normal. They're coming from the urinary tract. Lipids. We talked about this yesterday. When you see lipids in the urine, that's concerning for nephrotic. Nephrotic syndrome. Sometimes you see what they call the Maltese cross. That's lipids in the urine. Cast. Okay, so I'm going to cover on this because we're going to talk about an RPGN. So the cast, they form basically for a proteinaceous matrix, and the tubules, they produce a protein. I don't know if you heard about the tan-horsel glycoprotein. It's the matrix form this cast, and you can form a cast from any substrate, either from red blood cells, from white blood cells, from epithelial cells, or like for instance, this is a hyaline cast, which is it's a pretty benign cast. You can see this type of cast when the patients have urinary stasis, like low urinary flow states. Let's say the patient is dehydrated. We've been working, see patients at the Cardiovascular Institute for 12 hours, and being able to drink. So you can see some urinary hyaline casts. The granular casts are more consistent with ATN. So if they mention on the boards the word granular cast, just make sure that you think about ATN. So, but it's more like degradation of the epithelial cells into this granular cast. You can see waxy cast and in patients with acute kidney injury or like a rapidly progressive glomerulonephritis. I've never seen one, and trust me, I've seen many types of urine, so it's not as frequently found than this one. This is a red blood cell cast, so you can see the cast, and if you pay attention, you see the RBCs inside of the cast. And I already told you this is not normal and it's pathognomonic for glomerulonephritis. You see hemoglobin cast in patients with rhabdo or myoglobin cast in patients with some hemolytic anemias. You can also see this. This is a leukocyte cast, and again we can see this in infection or acute interstitial nephritis. Okay, urine microscopy. Bye guys.
See you tomorrow.
Bye, honey. You don't close that gate, right?
No. This is her.
Oh, she's here? Okay, thanks, buddy. Okay, so the uric acid crystals, they can have a different spectrum of appearances, but we only find these uric acid crystals in what kind of pH? Urine pH, I told you guys?
Acidic.
Acidic. There you go. So only acidic. It doesn't happen in alkaline urine. So, but you can see like different shapes. You can see like a rhomboid shape, irregular shape. See like different, but you see this in tumor lysis, or you see these in patients with severe hyperuricemia, either because they have cancer or because they have a tendency to have very high uric acid. These are the calcium oxalate crystals. Calcium oxalate, they precipitate, like probably in any urine pH, but for your boards, I think they want to show you like an envelope shape. You see the envelope shape, Mario? The top right.
Mm-hmm.
You see the envelope shape?
Mm.
Okay.
Yeah.
So that's one of the classic appearances of the calcium oxalate crystals. You can also see calcium phosphate crystals, and basically those typically they tend to precipitate in an alkaline urine, the calcium phosphate. And this is the magnesium ammonium phosphate. Have you guys heard about struvite stones? Okay, so the struvite stone, this is just a crystal. So if you imagine, if you have a bunch of these ones, they form into a stone, and it can be so severe that it can form what we call a Stackhorn calculi. Have you ever seen pictures of a Stackhorn calculi? So this type of crystal happens in, just gonna move here somewhere you can see. This type of crystal can actually happen in the setting of UTIs, like for instance, like when the patients have proteus or uroplasma, urolyticum. Those are organisms that can promote the formation of this magnesium ammonium phosphate, also known as struvite. Okay, this is a cholesterol crystal. We think about nephritic syndrome if they tell you lipids in the urine. Cystinuria is a congenital defect. These patients can have kidney stones, early kidney stones, and they have these hexagonal, very pretty looking crystals, and you have to do a 24-hour urine for cystine to be able to diagnose this condition. But if they ever show you a cystine crystal, it's a very pretty hexagonal form. Okay, and some drugs they can precipitate actually in the urine, and they can form crystals. Some of the most common ones, and I don't know if they may ask you that, is acyclovir. So if you guys end up seeing patients in urgent care, and you know that we use acyclovir very commonly for HSV1, HSV2, and we also use it for shingles. I saw patients with shingles. So the bottom line is that when you prescribe acyclovir, you tell the patients you're going to drink a lot of fluid, because this drug can precipitate and can form these crystals, and the patient can actually go into kidney failure from these crystals. Okay. So, you can see organisms, and these are like parasitic diseases, but we're not going to call it. You can see sperm. Okay, so this is the muddy brown, but I want you guys to memorize this type of urine sediment, because you're going to get that on your books. This is my son. He's eliminating those crystals. Okay, so let me. So now that you guys know that blood in the urine is not normal, I wanna give you a clinical scenario like I was giving you yesterday, the nephrotic syndrome patient. So the nephritic syndrome patient, these patients typically they can present with hypertension, more so than the nephrotic syndrome patients, and it can happen at any age. It can even happen in younger patients or even in kids. And there are some very well-defined conditions associated with nephritic syndrome. And you mentioned yesterday, what was the most common GN in the world? You told me the first one that you said that I told you that was nephritic.
The most common what?
The most common GN, glomerulonephritis. You mentioned one to me and I told you, no, that's nephritic.
Oh, IgA.
IgA nephropathy. So IgA nephropathy, it's more commonly seen in Southeast Asia and in Hispanics, but it can be seen in any race. IgA nephropathy is a very it's a tricky disease because the spectrum of severity can go from a pretty indolent, benign type of disease to a very severe form of nephritic syndrome, causing accelerated renal failure and dialysis dependence. The classic patient that they may give you on your boards is a guy or a gal who basically ended up developing some sort of upper respiratory infection-like symptoms, and then about a week after or 2 weeks after, they have gross hematuria. Excuse me. So the physiopathology is poorly understood what happens, but when they do ultrastructural analysis of the glomeruli, these guys seem to have some sort of abnormal sticky immunoglobulin that deposits not only in the kidney but it also deposits in the liver and other organs, causing inflammation and attracting the inflammation cascade, complement level, and causing chronic inflammation in the kidneys. Again, a lot of the cases we don't diagnose because to be able to biopsy a patient very clearly, we need to know whether or not we're going to be treating this patient. So if I see a patient coming in with glomerular hematuria, a little bit of protein, very stable kidney function, I don't biopsy those patients because they may have pretty benign IgA nephropathy. I don't discharge them from my clinic. I still see them, but I explain to them that we will do a biopsy if things are changing, if the level of protein in the urine is increasing, or if the kidney function is changing. Yes, there is some utility on doing a kidney biopsy on these patients. So IgA nephropathy, again, can be seen in any age group, from children to the elderly. So that's the most common GN in the world. They ask you on your boards, IgA nephropathy. Okay, so we also have other forms of nephritic syndrome. Do you guys remember? What else? Do you guys remember what happens when you get a sore throat with strep? Or if you get a strep skin infection? Have you guys heard about post-streptococcal glomerulonephritis? So that's another condition that falls into the category of nephritic syndrome. The classic story is a guy or a lady who gets either a strep infection in the throat or a strep infection in the skin, like how do you call those lesions? Crusty? How do you call that lesion?
Impetigo.
Yeah, impetigo. And then a few weeks after, they present with signs of renal failure, including fluid retention. They start having Coca-Cola urine. That's basically the classic description they're going to give you on your boards, and fairly abnormal kidney labs. That patient probably has a post-strep gene until proven otherwise. And do you guys think this patient is in trouble? It's going to become dialysis dependent, or what do you think is the prognosis for this condition?
Good.
It's actually good. Usually, sometimes it's pretty severe, and the patients may require dialysis support, but most patients recover, and they're left with minimal to no residual damage. So that's basically post-strep GN, and there's another group of nephritic syndromes. So yesterday we were talking about lupus, right? We covered lupus, and we covered membranous lupus. But lupus is a disease that can go from all the spectrum. It can go from nephritic to nephrotic spectrum, and there's two types of lesions that are associated with accelerated damage to the kidneys. You probably don't need to know this, but one is called the focal proliferative lupus, and the other one is the diffuse proliferative, which is a more severe degree of disease, diffuse proliferative lupus nephritis. In these patients, they have the symptoms. Have you guys gone over the MD soap brain? mnemonic to learn.
I never.
Yeah, have you heard about that one?
No.
There's a little mnemonic about lupus because the American College of Rheumatology, the diagnosis of lupus is a little tricky, and you need to have
like
like
11
4 out of 11.
Yeah.
4 out of 11 criteria to be able to diagnose it. And so for your boards, you should probably review the MD soap brain, MD is malar rash, discoid rash, serositis, either because they have like pleurisy or they have like some sort of peritonitis. Let me see, MD soap. O, it stands for. Yeah, you have internet. Look it up. I'm not very good with these mnemonics, but it's important that you memorize them.
Oral ulcers.
Oral ulcers, thank you. A stands for
Arthritis.
arthritis.
Photosensitivity, pulmonary fibrosis. Blood cells for B. R is renal. R nods. A is ANA. I immunologic, so anti-SM and anti-double-stranded DNA. N is neuropsych. M is malar rash. Oh, MD. Oh, we went over that. Yeah. MD. I just got it.
Yeah. So basically, you have to know that, but from the renal perspective, these patients may present with a constellation of symptoms, but they present with nephritic features, including hypertension, protein in the urine. And the protein in the urine is not. Remember we talked about yesterday, nephrotic. They have a lot of protein. These patients, they can present with even less than 1 gram, or definitely less than 3. But it's a pretty aggressive disease if you miss it. If you don't diagnose these patients timely, the time is golden in this population. You have to be able to diagnose them as quickly as possible to be able to treat them.
Just
patients,
the systemic lupus population or the all of nephritic?
all of the nephritics with rapid, like there is a syndrome called RPGN. There's 4 diseases that causes an RPGN, and those fall into the nephritic syndrome category, and those are like true nephrology emergencies. If you miss them, your patients can get in big trouble. So one of them is lupus, like diffuse proliferative lupus is one of the conditions that can give you an RPGN. The other group of diseases, I don't know if you heard about ANCA, like small vessel vasculitis. Have you guys heard about those diseases? They used to call them Wegener's and Church straws and microscopic cholangitis. There's like a group of inflammation of the blood vessels. So ANCA, small vessel vasculitis, is another type of RPGN. And ANCA stands for anti-neutrophil cytoplasmic antibodies. I'm sure you're going to encounter that when you're reviewing for your boards. It's another type of vasculitis that can cause an RPGN picture. And we have another disease, it's called anti-GBM. Have you guys heard about good posture disease? Yeah, so anti-GBM, it's another disease that can cause a rapidly progressive glomerulonephritis. We see this in young males, but we see it also in elderly females. And it's very important that we recognize that as a nephrologist, because the treatment for these patients, and they may ask you this question, because it's one of the few diseases that we treat that way, is with plasmapheresis, plasma exchange. Basically, it's like procedures similar to dialysis, but we remove plasma fluid and we infuse plasma to be able to get rid of these toxic antibodies.
For good pastures?
For good pastures. It's also known as anti-GBM. Glomerular basement membrane. Anti-GBM. Good pastures is basically a syndrome when they present with pulmonary and kidney complications. They can present with hemoptysis or diffuse alveolar hemorrhage, along with kidney disease. But again, it's so important that as a nephrologist, you don't miss those things, because the patients can really go the wrong way. So we have lupus, we have ANCA-related vasculitis, we have good postures, and we also have a type of disease. And the other one is like diseases that you're not going to be tested, like chronic anemia and things like that. But those are for the most part the nephritic syndromes. Suspected because we see blood in the urine and we see subnephrotic proteinuria, like anywhere from 1 to 3 grams. These patients, they present with hypertension. They may have systemic symptoms of systemic disease, like they can have either arthritis or they can have like a rash. They can have this ankylosing can cause a condition called mononeuritis multiplex. Mononeuritis multiplex. It's basically, they give you a scenario of a patient presenting with a drop arm or like drop foot out of the blue, and also they start giving you other hints, like the patients are having joint pains and some sort of rash, and that patient probably has an ANCA, a small vessel vasculitis, to prove it otherwise. So let me review the disease associations because they love this question on the boards. So yesterday I told you guys that hepatitis B is associated with secondary membranes. Remember? We covered that yesterday. I also told you that hepatitis C is associated with membranous proliferative glomerulonephritis. And I also told you that non-Hodgkin's lymphoma is associated with minimal change disease. And I also told you that secondary membranous is associated with solid organ malignancies. There is another disease that is associated with hepatitis B, and it's called polyarteritis nodosa. I don't know if you heard about that one or not. And they may show you a picture of a kidney with multiple microaneurysms in the arteries. Like they show you an angiogram, the renal angiogram picture. You see a bunch of little aneurysms, and those aneurysms are basically the hallmark of this disease, and it's commonly associated. It's a common complication. It's not, I wouldn't say common, but it's a board favorite, and the disease association is with hepatitis B. So I want you guys to remember that because they will ask you that. And I also told you yesterday that patients with HIV or obesity, they can develop FSGS. Remember that I told you guys? FSGS? Okay. Let me think about what else. What else are we missing? We talked about the urine sediment. We talked about the kidney masses, right? There's some. I'll show you about kidney masses.
Like polycystic kidney disease.
Polycystic kidneys and renal cell carcinoma. You can know that.
What's the one that looks like a sponge?
Medullary.
Yeah.
So basically, tumors, these are like more like a urological, not so much lymphological. But I need to know this because when I get a lot of like calls like, oh, what is that? So basically, tumors can happen any way, any part of the urinary tract. From the lower urinary tract, we have obviously bladder cancer or urethral diverticulum, or also the neurogenic bladder. We covered that yesterday. And posterior urethral valves, you know which condition is that associated in boys? You guys remember? Usually kids. Posterior urethral valves are associated with recurrent UTIs and unexplained fevers in boys. And it's important to address this because eventually down the road, these kids, they may not develop reflux nephropathy. And they develop FSGS and they go into kidney failure. So a lot of times when I have a young adult male with kidney failure, we can't really prove where it came from, but that's probably the reason of him having this. So in the upper urinary tract, you can have like stone duplication, reflux, or a uterus cell. In the kidney, we have the angiomyolipoma, which is benign or malignant. You guys remember the angiomyolipoma? It's a pretty benign tumor. And sometimes patients end up getting a nephrectomy for that, like my mom did. But it's a pretty benign tumor. And you also have cystic masses, or ectopia, or horseshoe kidneys. I'll talk about the polycystic kidneys later. And in the adrenal gland, you can have an adenoma, or you can have a pheochromocytoma. Remember when we talked about hypertension? You guys were here, right? Mm-hmm. When I came with a big. So pheochromocytoma has a very distinct radiographic appearance, to the point that if the radiologists feel there's a pheochromocytoma, you better believe them, because it's almost a pneumonia. And a myolipoma, which is a benign lesion, but sometimes it can be treated aggressively. Okay, so this guy's a 64-year-old with a brain mass, and when they did an abdominal CT, this guy ended up having this lesion to the kidneys, right? And this is a like it's an adrenal metastatic adrenal cancer. And adrenal adenomas are very common. You know, like they can be present in like 3% of the population. That's a pretty large number. And we don't do anything. We don't do anything because they, for the most part, they're benign. But when they're very big, if you remember from my talk, like when they're greater than 3 centimeters, we're kind of obligated to work them up because it may be related to a malignancy. So the larger, the more likely to be malignant. But the take-home message is that they're pretty benign masses. Okay, so you can actually diagnose them with an MRI. You just do an MRI with gadolinium, and you can see there's an obvious signal loss because they're pretty vascularized. They wash out the contours very quickly. Some of them can be functional, and some of them they're non-functional. I would say most of them are non-functional. For the ones that are functional, they can present with primary hyperaldosteronism. Remember we talked about this? We talked about Conn syndrome because they have a functional adenoma, and we only recommend removal when it's enlarging, when it's pretty big. Those patients do require, and sometimes they can be responsible for Cushing disease. So adrenal metastasis, you can see that it's a very common site of metastasis because the adrenal glands are highly vascularized, and they can be seen up to 27% in patients with dying from cancer. They have a lot of metastatic disease, but they can be seen in CT or MRI. They can be unilateral, bilateral, and this is the primary tumor and this is metastasis. Not good. If you have adrenal metastasis, not good. Okay. Alright, so this guy basically, he went in for a lithotripsy, and the urologist, he didn't recognize that this patient had a tumor here. So they were doing the lithotripsy, and he ended up releasing a lot of substances from, not only from the kidney stone, but from the tumor, and he went into cardiac arrest. If they give you a scenario like this is a pheochromocytoma. So anything crazy that happens to a patient during anesthesia, that's a pheochromocytoma. They love that question for whatever reason. Okay, so it's a functional tumor from the medullary, from the adrenal medulla, and it's rare. I don't know if you remember what I said. It's a rare tumor, and you can see from the CT and MRI findings, you can see it's 2 to 5 centimeters. It can be, they can have some areas of hemorrhage and areas of necrosis, and that's why radiologists are pretty confident calling it pheochromocytoma from the radiographic appearance. So on MRI, you can have like a light bulb appearance. That's what they call it. View. But it also has like some cystic formation. It's quite common. Okay, so unsuspected view. If they have a patient that they give them contrast, or they give them a catecholamine crisis, or they do a biopsy, or they do a lithotripsy, and they go. In these patients, you have to admit into the ICU and treat them aggressively with beta blocker and alpha blockers. Okay. So this woman is a 42-year-old with vague abdominal pain. It's a pretty large mass right here. So adrenal myelopoma. They're rare. They're not commonly seen. And when you, with the new imaging modalities that we have, they can tell whether or not this is fat. And we don't take it out, but some urologists, they feel very uncomfortable because there's a small chance that this may be a malignant tumor. These are myelopomas. They can be huge. Look at this one.
Wow. And they don't want to remove that, most of them?
I mean, most urologists, when a mass is like greater than 3 centimeters, it's probably more like a medical legal thing. Because even if the radiologists call it like, oh, this is a myelopoma, there's a small chance that this may be some carcinoma hiding in there, and I think most urologists will feel uncomfortable not doing anything about it. If they don't do anything about it, it's because the patient is adamant about not doing surgery. You know, you can imagine if somebody sues you from not taking out something that you thought was benign, it's pretty messed up. Okay. So the next question that you're confronted when you have a kidney mass, you think about, oh, this is a solid mass or this is a cystic mass. Solid is never good in the kidney. Cystic, most cysts are simple cysts. We don't worry about those. Just tell the patient it's like an aging process of your kidney, and that's how I see it. It's like when we start developing all these molds and all these like keratosis, it's the orogenic keratosis and how do you call these precancerous lesions in the skin? That's aging of the skin. Cyst to me is like an aging process of the kidney. But ultrasound is useful to distinguish between simple cyst versus complex cyst, and when you're concerned about a solid component, you have to do an enhanced CT. Enhanced CT means contrast. Sometimes giving contrast to a patient with kidney disease is problematic, but that's the only definitive way for doctors for the radiologists to know whether or not this patient has a solid mass component. So there's a classification. You don't need to know this, but I just want to cover briefly. So there's a Bosniak classification. So Bosniak 1, it's a pretty benign simple cyst. Bosniak 2, maybe has some hairline septations. Don't do anything about it. We can forget about those. When you have a Bosniak 2F, F is for follow. You follow those patients because the cyst looks a little bit more complex. And when you have a Bosniak 3 or 4, it's because there is a solid component, and those we have to take out because we may be dealing with a renal cell carcinoma. Okay. So an angiomyolipoma, we talked about this. They can be huge. They can cause compression symptoms, early satiety, abdominal pain. But these patients, they can also bleed once in a while, but they're rarely aggressive. And the management is not to do anything unless the patient really wants it out. Some of them, they can get embolized, and the results are pretty amazing. You just go in with a catheter, and they release the embolization substance, and it cuts off the circulation, and that's it. It just dies. Okay. So angiomyolipomas can be seen with a condition called tuberous sclerosis. Have you guys heard about tuberous sclerosis? These patients can have like these multiple fibromas everywhere, like in the skin, in the kidneys, in the brain. They can even present with seizures. And on your boards, they may give you a person with multiple angiomyolipomas, and they also with some hypopigmented lesions in the skin. I think they call it, what's the Canadian name of the tree?
Maple.
Yeah, like a maple leaf hypopigmented lesions. Patients with this condition called tuberous sclerosis. Again, the boards are not realistic. The boards, they want the students to memorize like crazy stuff instead of teaching them that the most important disease in this country is obesity. They teach you about like fever and tuberous sclerosis. I've never seen tuberous sclerosis, but they still want you to know these things. Okay, so this is a non-enhanced CT. This is a kidney, right? And you see a mass. So that's why if you don't give contrast, it's useless. After you give contrast, you can totally see that there is a cystic and there is a solid component to this mass. In these patients, he does have renal cell carcinoma. There are other renal cell carcinoma. It's a disease that if you diagnose it on time, you just need a nephrectomy and you save your patient's life. That's all you need, a nephrectomy. Sometimes when the disease has been spreading to other parts, you have to give chemotherapy. But sometimes the patients can present with bilateral renal cell carcinoma. Okay. So other non-fat containing masses of the kidney. So oncocytoma. It looks pretty ominous, that name, right? It's actually a very benign lesion. We don't do anything about it. And the ones that are malignant, renal transitional cell carcinoma, lymphoma, or metastasis. The oncocytoma. It's basically, they call it a spook wheel pattern. Radiologists are pretty comfortable calling it a benign lesion. So the renal lymphoma, that's one of the few conditions that can give you a big kidney. If they ask you about on your boards on a big kidney, you think about three conditions: early diabetic nephropathy that causes like hypertrophy from hyperfiltration, also renal amyloidosis, and also lymphoma or any type of infiltrated disease of the kidney can give you an enlarged kidney.
So renal amyloidosis, lymphoma, and
Early diabetic nephropathy can give you an enlarged kidney. You guys know what the size of a human kidney is? It's about 10 to 12 centimeters. It depends on your height. The taller you are, the larger your kidney is. So for an average height female is 10 to 12 centimeters. So sometimes you can see like a 15, 16 centimeter kidney on these conditions. Okay, let's see, the cyst, I already told you, most of them if it's a Bosniak 3, you need to take it out. That's a decision made by a urologist. Bosniak 4, you have to take it out. Most of these cysts are renal cell carcinomas. Okay, so take home messages. If you have fat in the adrenal gland, it's benign. If it's low, it's a small lesion, it's an adenoma. If it's big one, it's myolipoma. If you have microscopic fat in a renal mass, it's probably an angiomyolipoma, and there's really no exceptions. All other solid renal masses, they're pretty much consistent with renal cell carcinoma. And in practice, for renal cyst, forget it, follow it, or cut it out. Bosniak 1 and 2, forget about it. Bosniak 2F, we follow. Bosniak 3 or 4, take it out. It's a simple way of remembering. These are more like pharmacology follows. Very good. So, cover the renal. Oh, polycystic kidneys. So, polycystic kidneys is a progressive disease. Your patients, they eventually end up requiring dialysis if they live long enough. There's two types of polycystic kidney disease. Polycystic kidney disease type 1 and type 2. They have some isolated genes that we already know that, you can actually send your patients for genetic counseling. Let's say that a mom or dad is concerned about the possibility of his children having it. We have genetic testing available. We don't encourage that we do screening ultrasounds in children because they may be too young and they're still not showing anything, so it doesn't entirely rule it out. So we, as a general rule, we wait until they become adults. And in fact, it's better not to know these type of things if you're thinking about like buying long-term disability insurance or life insurance, because that can make you completely ineligible for any of these things. But the management of these patients, we don't really have effective therapies. It's just a matter of giving them an ACE or an A or B and wait. Some patients, they have a very slow progression. Some patients have an accelerated progression. But a lot of the symptoms come from compression symptoms. I already told you that the normal size of a human kidney is how much?
10 to 12.
10 to 12. So the kidneys, big polycystic kidneys, can be as big as 20 or 22 centimeters. So just imagine like this is a normal kidney, and you're dealing with a kidney this big. And a lot of the complications come from compression. Like they cause pain syndromes. They can have bleeding, like the cyst can actually rupture and cause gross hematuria. They can become infected, and there's an increased risk of malignancy, which is pretty hard to follow up these patients, because every time they do an ultrasound, they see a bunch of cysts, but the radiologist they almost never know whether or not there's a malignancy there. But most patients, they end up on dialysis, and there's really no effective therapy. They just need a transplant. When they have a lot of compression symptoms, they end up requiring a nephrectomy, just to treat the symptoms. But we don't do routine nephrectomy on all patients, only when they have a lot of symptoms. Let's see if I have the email, if I'm missing. Do you guys have the email, or Dr. Register the email?
Is it this what's it called? PDF?
Oh, yeah, that's that. It's just the list of,
A urology renal?
yeah. Or,
The green screen.
Yeah.
It's right there.
Oh, it's not good.
Yeah.
This is a very complicated mechanism that we're not going to talk about.
Oh, there and now.
So, acute interstitial nephritis. First thing I want to remind you guys is that when we talk about acute kidney injury, ATN per renal, ATN per renal, ATN per renal, and then the other stuff like RPGN or interstitial nephritis. Fortunately, it only accounts for 5% of the causes of acute kidney injury. But it's important not to miss it, because if you miss it, your patient is going to have progressive renal failure and sometimes irreversible renal failure. So the classic story is this is a type 4 reaction. I don't know if you guys remember from immunology. You got like type 1, type 2, type 3. So type 4 reaction is a cell-mediated reaction, and it doesn't happen the first time. The first time they're exposed to an antigen, either you call it an infection or a drug or some sort of autoimmune process, the body remembers, and then the next time you challenge them with the same drug, they're ready to respond with a full army of immunoglobulins and cells, causing massive inflammation and accelerated destruction of the kidney. We call it interstitial nephritis because, from the anatomical perspective, we have, in the microscopic view of the kidney, we have the functional unit of the kidney, which is the nephron, and we also have the interstitium, which is all the collagen fibers holding on the tissue and supporting the blood vessels. So a lot of the inflammation, or most of the inflammation, happens in the interstitial space. That's why we call it acute tubular interstitial, because you're going to see infiltration of lymphocytes in both the interstitium and the tubules, causing the destruction and the damage. Most of the times, the etiology of this condition is drugs. I would say probably 80% of the time it's drugs, and like I mentioned briefly, most of the time antibiotics, and the more common offenders are cephalosporin or beta-lactam antibiotics. I wouldn't say cephalosporin. Let me rephrase that. Beta-lactam antibiotics. But you can also see that with other groups of medications. I have some lists here, like PPIs and other drugs. But you can also see this with infections. Actually, some infections, they can, like leptospirosis, can cause a severe form of interstitial nephritis. You can also see this in systemic diseases like lupus, Sjögren's syndrome, and others. The list. You guys want to read the list? But for the most part, it's like beta-lactams, but also Cipro, INH, macrolides, rifampin, tetracyclines, NSAIDs. Pretty much all of them can cause acute interstitial nephritis. Diuretics, you can cause AIN with Lasix, thiazides, and triamterene. Other medications like allopurinol, acyclovir, amlodipine. I mean, the list is fairly long. Bacteria, you can have Legionella species, E. coli, other agents, leptospirosis. I mean, the list is so long. You're never going to be able to memorize this list. But the bottom line is that these patients, they can present with fairly rapid progression of renal failure. They can have no manifestations other than they start peeing less when they're in the hospital. And a lot of these cases happen in the inpatient setting. We sometimes see this as an outpatient, but most of these patients, they end up getting admitted because they keep taking the medication, and it takes a little while for the doctors to figure it out, like, well, we're dealing here with an acute interstitial nephritis case. But some patients can have like a rash. I have a picture of the rash here. So it's a pretty impressive rash. It's usually in the lower extremities, but it can happen anywhere. And patients can present with fever. Like, that's the classic triad of acute interstitial nephritis. They present with fever, rash, and eosinophilia, and renal failure, obviously. So when you see peripheral eosinophilia, you think about what conditions?
Allergic.
I'm sorry?
Allergic.
Allergic reactions. What else?
Oh, isn't it parasitic?
Parasitic diseases and acute interstitial nephritis.
Oh.
With at the end is also an allergic reaction. It's just like systemic allergic reaction. So that may be a hint if they give you a question on your boards and they give you some sort of eosinophilia, peripheral eosinophilia. Just think about acute interstitial nephritis. So it's a macular papular rash. You can see it in up to 40% of the patients. Okay. So how do you suspect it? Again, rise in the creatinine. There's a test called urine eosinophils. Have you heard about that? Urine eosinophils may not be the best or the most accurate test because you can have urine eosinophils in many conditions. If you have prostatitis or if you have a UTI or pylori, you're going to have some eos. So it's more useful when you have the right setting, like the right patient with the right history and with few WBCs, and if you have pretty positive urine eos, you're probably dealing with a real deal. So you suspect it again in the right patient, and see what else. Yeah. So most patients, they improve right away. So you don't need to jump and do a biopsy in these patients, because if you stop the offending agent, like you expect to see an improvement in the next 24 hours.
Even without treatment?
With no treatment. It's just a crazy allergic reaction. Just imagine, when you guys think about this condition, just imagine a crazy reaction in the kidney from, most of the time, from a drug, like probably 80-90%. They may give you an antibiotic, they give you Cipro or beta-lactam. You just stop it, and this patient, they start getting better. When do we biopsy? We biopsy patients when they're not getting better, because either the damage was so severe, or because you're considering giving this patient steroids. Every time I want to make the decision about giving steroids to someone, I want to know what I'm treating. Why? Because steroids, they carry significant side effects, and if let's say that if you have a serious disease like an RPGN, and you miss that, and you're treating it with the steroids, the next time that you do a biopsy, you may have you may mask an important diagnosis. So when I'm getting ready to give steroids, I usually biopsy the patient. I already told you about the urine use, so with a grain of salt. Basically, in the right setting, with the right history, they have a value, but they can be very non-specific and seen in many other conditions. There's a type of test called a gallium scan. I never do this because I think it's a waste of time. It's in the textbooks. Some doctors do it. It just lights up inflammation in the kidneys. But so many other things can give you this, like iron overload or liver disease, can give you a positive finding. So indications for renal biopsy, I already told you, like the patients, if you're going to give steroids, you better biopsy the patient. If you're not sure if this is AIN, you better biopsy your patient. And at the end of the day, it just goes down to your clinical judgment. And you need to make sure it's safe for your patient to have a biopsy. Like we were talking about yesterday, you don't biopsy everyone. You biopsy somebody who's stable enough to get a biopsy. You don't biopsy a patient in ICU. You have to have, the patients need to be able to lay down on their tummies, flat. Need to be able to cooperate because they, you have to be synchronic with the breathing. You measure, you mark, and then you fire. And if the patient is not cooperating or is moving, there's no way you can do a safe renal biopsy. It's pretty deep. Sometimes we go like this deep, like 7, 8 centimeters, 10 centimeters, to be able to get a good sample of the cortex.
Do they get anesthesia?
Local.
Oh.
Only local.
So it's very painful, right?
It's funny because the procedure itself, let's say that you're laying down, I mark, I put anesthesia, local anesthesia. So the needle size is probably a big needle. It's probably like an 18 rad. That's probably like a 22 or something. But anyway, you end up advancing all the knife all the way down, and then they don't feel any pain. But the minute that you actually get the kidney, they jump, they flinch.
Get it as in like pull it out, or get it as in
as it fires. As it fires, most patients they jump. But you tell them, you're gonna feel like a little bit of pain, but for the most part, it's okay. Some patients they do complain of pain, but it's not pleasant. Yeah, that's why you think about who you're gonna biopsy. Yeah. So these are like the H&E picture of a interstitial nephritis. I don't know if you've seen a normal H&E, but like massive infiltration of lymphocytes, eosinophil, plasma cells, and neutrophils.
What's an H&E?
Hematoxylin and H&E is hematoxylin and eosin.
Is that just a stain? A type
Yeah,
of
the
stain?
name of the
Oh,
stain
okay.
is hematoxylin and eosin.
It's fine. I just wanted to know what it was. Not the name.
Hematoxylin and eosin stain.
Yeah, hematoxylin and eosin stain.
Thank you.
I'll show you images to see how different it looks when it's not. Probably like tubules, but you don't see a lot of inflammation. Whereas here, you see like this is completely occupied by massive amounts of white blood cells. Okay, so differential diagnosis. On your boards, they may give you somebody with contrast, like cholesterol emboli, like somebody, let's say that the person had a cabbage, or they have a carotid endarterectomy, or they have, let's say Dr. Ben-Zur put a stent, so there's a lot of manipulation of plaque, and that plaque can actually migrate, and it can cause renal failure. We call that cholesterol emboli. So the difference between this entity and acute interstitial nephritis is the timing, because they want to trick you. They want to give you a patient who is in renal failure and has a rash, and then you think like, oh, of course they're talking about acute interstitial nephritis. No, they're talking about cholesterol embolization, but they have to give you the right history. Let's say like manipulation of plaque, either from a cabbage or from a carotid endarterectomy, and the timing. These patients, they tend to have like a pretty subacute onset. It doesn't happen like within hours or days, like acute interstitial nephritis. It happens like weeks after, like 2 or 3 weeks. And the rash, remember I showed you the rash was very different? Rash was like more like a macular papular. This type of rash, we call this livido reticularis. Like, I don't know if you talk about, do you see any forensic in your training? Any forensic medicine? Okay. These are the type of markings that you see when somebody dies, like after a few hours, like 3 to 4 hours after you die. Like livido reticularis. So you see this kind of pattern when you have embolization of cholesterol. So they may want to trick you because they want to give you, the urine also has urine eosinophils in these patients, but I don't think they're going to ask that question, but I just want to bring it up. Okay, the treatment, immediate stopping these medications, and sometimes you need to give them immunosuppression. Most of the patients respond just to prednisone, but sometimes the inflammation is so severe that you need to give them like cytoxin medication, more strong medication. The prognosis is actually pretty good when you're able to stop it. Excuse me. That's why it's so important to diagnose it very quickly. This is the what the name of this guy. This is the first guy who crossed the Atlantic. Pilot. His name was. He's a very famous American pilot. He died from analgesic nephropathy, and this is a very common disease in our society. I have 170 dialysis patients, and from those 170, probably 10 of them are there because of ibuprofen, and that's why I want to raise awareness for you guys because you're going to be prescribing a lot of NSAIDs. So the single most important risk factor for developing analgesic nephropathy is the duration of therapy. Like, let's say if you have a patient, a right candidate, let's say like somebody with a sports injury, somebody that came in asking for, like an acute injury, you prescribe your NSAIDs and you educate the patient. If pain continues, you need to come see me, or you need to, I'll refer you, because in our society, people abuse these medicines because they need to function. And the way they sell it, if you pay attention to those commercials, the way they sell it to people is like, take an Advil every day, or take an Aleve every day to control pain. And they don't tell you, just don't take it every single day of your life. And a lot of people, like holding 2, 3 jobs, they take this stuff to function. And it's extremely toxic to the kidneys. It's extremely toxic. So the single most important is the duration of therapy. And that's one of the types of acute interstitial nephritis. The NSAIDs can injure the kidney in many ways. I told you yesterday it can cause minimal change. It can also cause membranous, but it can also cause acute interstitial nephritis, or it can cause another type of interstitial nephritis that is called chronic granulomatous interstitial nephritis. And it can even cut down your blood flow to the kidneys, because remember, they block the prostaglandin pathway. That's how they provide relief of inflammation. So make sure you don't give these patients chronic NSAIDs. We call this sick kidney, small indentated calcified kidneys. So that's what we see in the postmortem specimens, sick kidneys. There is another type of disease called Chinese herb nephropathy, and we don't see it very often, but I always inquire about Chinese herbal medicine when I see a consult, because some of these herbs can be associated with a lot of kidney toxicity. So it's a specific type of Chinese herbal medicine. Lithium, you guys are going to go into psychiatry. Lithium is very toxic to the kidneys, and it can cause acute interstitial nephritis. or chronic interstitial nephritis. And the sad thing about this entity is that even if you stop the lithium, the patients, they continue to progress. And they may become dialysis dependent. I have 2 patients in dialysis unit from lithium.
Are they bipolar?
Yeah, it's an amazing medication, and psychiatrists still rely on it a lot because they haven't been able to come up with better therapies for bipolar, but it can be very toxic. So the first problem that these patients taking lithium develop is they develop nephrogenic diabetes insipidus. They feel very thirsty all the time, and you shouldn't restrict these patients from drinking because that's how they're able to maintain an adequate soluble balance. They drink a lot of fluid all the time. And that happens almost invariably on everybody taking lithium. They get some degree of nephrogenic diabetes insipidus, but some patients are not that fortunate and they end up developing inflammation. And that's why these patients, they have to have routine monitoring of their renal function. And sometimes I had a consult like 2 months ago. The lady came in and clearly she had a very slow decline in her renal function. I sent a letter to the psychiatrist telling you may want to consider changing this medicine because it's just not good for her. Sarcoidosis, I don't know if you heard about sarcoidosis, mostly a pulmonary disease, but it can also manifest in the kidneys. And the mechanistic injury is the acute interstitial nephritis. There's a condition called Tino syndrome. You need to know about this. It's a zebra, and I hope I never see it. Some sort of uveitis and interstitial nephritis. It's in young females. IG4, this is a new group of diseases you need to know about. They can cause autoimmune pancreatitis and autoimmune interstitial nephritis. You need to know about this. So interstitial nephritis is part of the acute kidney injury syndrome, but it's not common, and it's type of allergic reaction. So the take-home message is not common, only about 5%, and identification and prompt discontinuation of the offending medication is actually the treatment choice. Any questions, guys? Your last day is, you said next week or?
The 30th.
Oh, no, you still have.
Last month. Yeah. We're here.
We're here. We have 2 more weeks.
I think I'm gonna, maybe if I come next time, we can do acid base. Acid base is